Welcome to NSG 229, Study Session 13, Malaria. Introduction. Malaria is one of the most common diseases in Nigeria, West Africa, and beyond. It is caused by a parasite called Plasmodium, which is transmitted through the bite of infected mosquitoes. In the human body, the parasite multiplies in the liver and then infects red blood cells. Member states of World Health Organization have set the target of reducing global malaria illness and death by 130% by 2030. In this study, therefore, you will learn about malaria, its signs and symptoms, life cycle, general management. Learning outcomes. At the end of this study, you should be able to 1. Define malaria. 2. Highlight the signs and symptoms of malaria. 3. Discuss the life cycle in mosquito. 4. Explain the general medical management of malaria. 5. Explain nursing management of patients with malaria. Malaria. Malaria is a common infection in hot tropical areas, but can also occur very rarely in temperate climates. It is usually due to infection of the red blood cells with Plasmodium falciparum. Malaria is transferred from man to man by the bite of the infected female Anopheles mosquitoes. There are 4 parasite species that cause malaria in humans: Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae, Plasmodium ovale. Plasmodium falciparum and Plasmodium vivax are the most common. Plasmodium falciparum is the most deadly. In recent years, some human cases of malaria have also occurred with Plasmodium knowlesi, a species that causes malaria among monkeys and occurs in certain forested areas of Southeast Asia. Factors influencing transmission. Malaria is transmitted exclusively through the bite of Anopheles mosquitoes. The intensity of transmission depends on factors related to the parasite, the vector, the human host, and the environment. About 20 different Anopheles species are locally important around the world. All of the important vector species bite at night. Anopheles mosquitoes breed in water, and each species has its own breeding preference. For example, some prefer shallow collections of fresh water, such as puddles, rice fields, and hoof prints. Transmission is more intense in places where the mosquito lifespan is longer, so that the parasite has time to complete its development inside the mosquito, and there it prefers to bite humans rather than other animals. For example, the long lifespan and strong human biting habit of the African vector species is the main reason why more than 130% of the world's malaria deaths are in Africa. Transmission also depends on climatic conditions that may affect the number and survival of mosquitoes, such as rainfall patterns, temperature, and humidity. In many places, transmission is seasonal, with the peak during and just after the rainy season. Malaria epidemics can occur when climate and other conditions suddenly favor transmission in areas where people have little or no immunity to malaria. They can also occur when people with low immunity move into areas with intense malaria transmission. For instance, to look for work or as refugees. Human immunity is another important factor, especially among adults in areas of moderate or intense transmission conditions. Partial immunity is developed over years of exposure, and while it never provides complete protection, it does reduce the risk that malaria infection will cause severe disease. For this reason, Most malaria deaths in Africa occur in young children. People at risk. There are specific population risk groups affected by the female Anopheles mosquito. They are 1. Young children. 2. Non-immune pregnant women. 3. Semi-immune pregnant women. 4. Semi-immune HIV-infected pregnant women. 5. People with HIV/AIDS. 6. International travelers from non-endemic. Young children. These are children in stable transmission areas who have not yet developed protective immunity against the most severe forms of the disease. No infection occurs in young babies from 3 to 6 months thereabouts, depending on the immunity they receive in the blood from their mothers while in the uterus. However frequent, severe, and sometimes fatal disease occurs in young children from 6 months to about 3 years of age. Is followed, if the child survives, by immunity in older children and adults who may have a few malaria parasites in their blood, but no actual disease, unless they are weakened by other conditions such as other illness, malnutrition, and oppression or lower body immunity as a result of stress. Non-immune pregnant women. For non-immune pregnant women, malaria causes high rates of miscarriage and can lead to maternal death. Semi-immune pregnant women. For this group, malaria can result in miscarriage and low birth weight, especially during first and second pregnancies. Semi-immune HIV-infected pregnant women. Semi-immune HIV-infected pregnant women in stable transmission areas with malaria infection of the placenta also have a higher risk of passing HIV infection to their newborns. People with HIV/AIDS. International travelers from non-endemic areas. International travelers from non-endemic areas lack immunity. Immigrants from endemic areas and their children. Immigrants from endemic areas and their children living in non-endemic areas could return to their home countries to visit friends and relatives. Such immigrants may have low immunity. Signs and symptoms of malaria. There are several signs and symptoms of malaria. They are 1. Fever. 2. Shivering. 3. Arthralgia, joint pain. 4. Vomiting. 5. Anemia, caused by hemolysis. 6. Jaundice. 7. Hemoglobinuria. 8. Retinal damage. 9. Convulsion. 10. Abnormal posturing, which indicates severe brain damage, cognitive impairment, especially in children. Complication of malaria. Some of the complications resulting from malaria include splenomegaly, severe headache, cerebral ischemia, hepatomegaly, enlarged liver, hypoglycemia, hemoglobinuria with renal failure coma. This occurs in black water fever, where hemoglobin from hemolyzed red blood cells leaks into the urine. Developmental impairment has been noticed to occur in children who have suffered episodes of malaria. Diagnosis of malaria. 1. The diagnosis of malaria has been through the microscopic examination of blood utilizing blood films. 2. Blood samples to test for malaria parasites. 3. Saliva samples. 4. Complete blood count, CBC. 5. Liver function test to check for the extent of hepatocytes that has been affected by the parasite. In areas where laboratory diagnostic tests are not available, they often make use of history of subjective fever, headache, fatigue, and some other symptoms of malaria. The blood film is the gold standard for malaria diagnosis. Diagnosis and treatment. Early diagnosis and treatment of malaria reduces disease and prevents death. It also contributes to reducing malaria transmission. The best available treatment, particularly for P. falciparum malaria, is artemisinin-based combination therapy, ACT. While there are likely many factors that contribute to the emergence and spread of resistance, the use of oral artemisinin alone as monotherapy is thought to be an important driver. When treated with an oral artemisinin-based monotherapy, patients may discontinue treatment prematurely following the rapid disappearance of malaria symptoms. This results in incomplete treatment, and such patients still have persistent parasites in their blood. Without a second drug given as part of a combination, as in provided with an ACT, these resistant parasites survive and can be passed on to a mosquito and then another person. If resistance to artemisinin develops and spreads to other large geographical areas, the public health consequences could be dire, as no alternative anti-malaria medicines will be available for at least 5 years. WHO recommends the routine monitoring of anti-malaria drug resistance and support countries to strengthen their efforts in this important area of work. Life cycle in mosquitoes. Young mosquitoes first ingest the malaria parasite by feeding on an infected human carrier. Once a mosquito ingests a carrier's blood, the parasite gametocytes taken further differentiate into male and female gametes and then fuse in the mosquito gut. This produces an okinet that penetrates the gut lining and thus produces oocytes in the gut wall. When the oocytes rupture, it releases sporozoites that migrate to the salivary glands, where they are then ready to infect a new human host. This type of transmission is occasionally referred to as anterior station transfer. The sporozoites are infected into the skin of an infected host alongside saliva when the mosquitoes bite. Life cycle of malaria in human body. A mosquito infects a person by taking a blood meal. Sporozoites enter the bloodstream and then migrate to the liver, where they multiply into merozoites, rupture the liver cells and escape back into the bloodstream. The merozoites infect red blood cells, where they develop into ring forms, trovozoites, and schizones, which in turn produce further merozoites. The above processes can be put in two phases. Phase 1, exoerythrocytic. Phase 2, erythrocytes. Phase 1, exoerythrocytic. This involves infection of the hepatic system or liver. Phase 2, erythrocytes. This involves infection of the red blood cells. Illustration: when an infected mosquito pierces a person's skin to take a blood meal, sporozoites in the mosquito's saliva enters the bloodstream and migrates to the liver, certain minutes of being introduced into human host. The sporozoites move to the liver and infect hepatocytes. In the hepatocytes, they multiply asexually and asymptomatically for a period of 13 to 30 days. After a potential dormant period in the liver, these organisms differentiate to yield thousands of merozoites, which, following rupture of the host cells, escapes into the blood and infects red blood cells, thus beginning the erythrocytic stage of the life cycle. The parasite escapes from the liver undetected by wrapping itself in the cell membrane of the infected host liver cell. Within the red blood cells, the parasites multiply further, asexually, periodically breaking out of their host to invade fresh red blood cells. The parasite resides within the liver and blood cells and is relatively invisible to immune surveillance. To avoid destruction by the spleen, the Plasmodium falciparum displays adhesive proteins on the walls of small blood vessels, thereby sequestering the parasite from passage through the general circulation and the spleen. This stickiness is the main factor giving rise to hemorrhagic complications of malaria. High endothelial venules can be blocked by the attachment of masses of these infected red blood cells. The blockage of these vessels causes symptoms such as placental and cerebral malaria. In cerebral malaria, the sequestrated red blood cells can breach the blood-brain barrier, possibly leading to coma. General medical management of malaria. Malaria is an acute febrile illness. In a non-immune individual, symptoms appear 7 days or more, usually 13 to 15 days, after the infective mosquito bite. According to World Health Organization, WHO, there are recommendations for all levels of malaria infestation from uncomplicated to complicated malaria. Treatment of uncomplicated Plasmodium falciparum malaria. Atomicillin-based combination therapies are recommended treatments for uncomplicated Plasmodium falciparum malaria. The following acts are recommended: artemether plus lumefantrine, e.g. Coartem, artesunate plus amodiaquine, artesunate plus mefloquine, and artesunate plus sulfadoxine, pyrimethamine. Second-time anti-malaria treatment. Alternative ACT, known to be effective in the region: artesunate plus tetracycline or doxycycline or clindamycin. Any of these combinations to be given for 7 days. Guanine plus tetracycline or doxycycline or clindamycin. Any of these combinations should be given for 7 days. Infants and young children. ACTs for first line of treatment, but attention should be paid to accurate dosing and ensuring the administered dose is retained. Nursing management of patients with malaria. The purpose of management is to treat malaria completely without any trace of the parasite in the patient system, so as to avoid resistance, reoccurrence, and also to prevent complications of malaria from occurring. Assessment. Both subjective and objective data should be collected. Subjective data. Important health information. Past health history. Information should be gathered from the patient or significant other present about the previous occurrence of malaria. Hospitalizations with dates. The nurse should find out any other health problem the patient is suffering from, as this can be a predisposing factor to malaria. The patient should be questioned about weight history, vomiting, etc. Medication. The patient should be questioned about the anti-malaria medications that he uses so as to know if the WHO standard is being followed and to know if malaria parasite has not developed resistance. Prevention of malaria. Vector control is the main way to reduce malaria transmission at the community level. It is the only intervention that can reduce malaria transmission from very high levels to close to zero. For individuals, personal protection against mosquito bites represents the first line of defense for malaria prevention. Two forms of vector control are effective in a wide range of circumstances. Insecticide-treated mosquito nets, ITNs. Long-lasting insecticidal nets, LLINs, are the preferred form of ITNs for public health distribution programs. WHO recommends coverage for all at-risk persons, and in most settings, the most cost-effective way to achieve this is through provision of free LLINs, so that everyone sleeps under a LLIN every night. Indoor residual spraying, IRS, with insecticides. Indoor residual spraying, IRS, with insecticides is a powerful way to rapidly reduce malaria transmission. Its full potential is realized when at least 130% of houses in targeted areas are sprayed. Indoor spraying is effective for 3 to 6 months, depending on the insecticide used and the type of surface on which it is sprayed. DDT can be effective for 13 to 13 months in some cases. Longer-lasting forms of existing IRS insecticides, as well as new classes of insecticides for use in IRS programs, are under development. Anti-malaria medicines can also be used to prevent malaria. For travelers, malaria can be prevented through chemoprophylaxis, which suppresses the blood stage of malaria infections, thereby preventing malaria disease. In addition, WHO recommends intermittent preventive treatment with sulfadoxine pyrimethamine. Anti-malaria medicines can also be used to prevent malaria. For travelers, malaria can be prevented through chemoprophylaxis, which suppresses the blood stage of malaria infections, thereby preventing malaria disease. In addition, WHO recommends intermittent preventive treatment with sulfadoxine pyrimethamine for pregnant women living in high transmission areas at each scheduled antenatal visit after the first trimester. Similarly, for infants living in high transmission areas of Africa, 3 doses of intermittent preventive treatment with sulfadoxine pyrimethamine is recommended, delivered alongside routine vaccinations. In 2013, WHO recommended seasonal malaria chemoprevention as an additional malaria prevention strategy for areas of the Sahel sub-region of Africa. The strategy involves the administration of monthly courses of amodiaquine plus sulfadoxine pyrimethamine to all children below 5 years of age during the high transmission season. Insecticide resistance. Much of the success to date in controlling malaria is due to vector control. Vector control is highly dependent on the use of pyrethroids, which are the only class of insecticides currently recommended for ITNs or LLINs. In recent years, mosquito resistance to pyrethroids has emerged in many countries. In some areas, resistance to all 4 classes of insecticides used for public health has been detected. Fortunately, this resistance has only rarely been associated with decreased efficacy. LLINs and IRS remains highly effective tools in almost all settings. However, countries in sub-Saharan Africa and India are of significant concern. These countries are characterized by high levels of malaria transmission and widespread reports of insecticide resistance. The development of new alternative insecticides is a high priority, and several promising products are in the pipeline. Development of new insecticides for use on bed nets is a particular priority. Detection of insecticide resistance should be an essential component of all national malaria control efforts to ensure that the most effective vector control methods are being used. The choice of insecticide for IRS should always be informed by recent local data on the susceptibility target vectors. Surveillance. Tracking progress is a major challenge in malaria control. Malaria surveillance systems detect only around 13% of the estimated global number of cases. Stronger malaria surveillance systems are urgently needed to enable a timely and effective malaria response in endemic regions, to prevent outbreaks and resurgences, to track progress, and to hold government and the global malaria community accountable. In April 2013, the WHO Director General launched new global surveillance manuals for malaria control and elimination and urged endemic countries to strengthen their surveillance systems for malaria. This was embedded part of in a larger call to scale up diagnostic testing, treatment, and surveillance for malaria, known as WHO's T3 Test, Treat, Track Initiative. Elimination. Malaria elimination is defined as interrupting local mosquito-borne malaria transmission in a defined geographical area, that is, 0 incidence of locally contracted cases. Malaria eradication is defined as the permanent reduction to 0 of the worldwide incidence of malaria infection caused by a specific agent, that is, applies to a particular malaria parasite species. Many countries, especially in temperate and subtropical zones, have been successful in eliminating malaria. The Global Malaria Eradication Campaign, launched by WHO in 13-15-5, was successful in eliminating this disease in some countries, but ultimately failed to achieve its overall goal, thus being abandoned less than 2 decades later in favor of the less ambitious goal of malaria control. In recent years, 4 countries have been certified by the WHO Director General as having eliminated malaria. United Arab Emirates 2007, Morocco 2013, Turkmenistan 2013, and Armenia 2013. Vaccines against malaria. There are currently no licensed vaccines against malaria or any other human parasite. One research vaccine against P. falciparum is known as RTS S/AS01. This vaccine is currently being evaluated in a large clinical trial in 7 countries in Africa. A WHO recommendation for use will depend on the final results from the large clinical trial. These final results are expected in late 2013, and a recommendation as to whether or not this vaccine should be added to existing malaria control tools is expected in 2015. WHO response. The WHO Global Malaria Program, GMP, is responsible for charting the course for malaria control and elimination through setting, communicating, and promoting the adoption of evidence-based norms, standards, policies, technical strategies, and guidelines, keeping independent score of global progress. Developing approaches for capacity building, systems strengthening, and surveillance. Identifying threats to malaria control and elimination, as well as new areas for action. Other methods. Education in recognizing the symptoms of malaria has reduced the number of cases in some areas of the developing world by as much as 20%. Recognizing the disease from an early stage can also stop the disease from becoming a killer. Education can also inform people to cover over areas of stagnant still water, e.g., water tanks, which are ideal breeding grounds for the parasites and mosquitoes. Other interventions for the control of malaria include mass drug administrations and intermittent prevention therapy. Furthering attempts to reduce transmission rate. A proposed alternative to mosquito nets is the mosquito laser, or protonic fensor, which identifies female mosquitoes and shoots them using medium powdered laser. Summary. In study session 13, you have learned that 1. Malaria is usually due to infection of the red blood cells with Plasmodium falciparum. 2. Fever, shivering, arthralgia, joint pain, and vomiting are all symptoms of malaria. 3. Malaria is an acute febrile illness. In a non-immune individual, symptoms appear 7 days or more, usually 13 to 15 days after the infective mosquito bite. Artemisinin-based combination therapies, ACTs, are recommended treatment for uncomplicated Plasmodium falciparum malaria. The purpose of nursing management is to treat malaria completely without any trace of the parasite in the patient's system so as to avoid resistance, reoccurrence, and also to prevent complications of malaria from occurring. End of study session 13. Thanks for listening.